Obliques capitus inferior. Well, think about this one. It's going to go from C2 spinous process to the lateral transverse process of C1. So what do we have here is a C1, C2 rotator. So again, densely innervated with muscle spindles. These muscles give off a lot of proprioceptive input and also are coordinated with the vestibular system and the vestibular nuclei to coordinate head motions, balance, proprioception, and input. But let's say I'm going to rotate to my right, and we're going to have activation of my right, my ipsilateral inferior obliquus muscle with this in rotation. So if I have a restriction of the posterior glide of the C1 on C2 on the right, that's the job of this inferior oblique muscle here. So we could have some hypertonicity forming this muscle as it pulls into the barrier. If I have pain going along with this, which I can, because that is a posterior meniscoid in C1, C2, which can become irritable, and it can be enlarged in post-concussive patients and chronic neck pain patients. So this inferior oblique muscle can be pulling into that painful, again, posterior structure. It could be inhibited, it could be facilitated. So I want to get a sense of how this muscle feels. And again, I can have implications at C2, C3 on that right-hand side, or even the left-hand side's ability to do it. So that's why it's important to really get a sense of what the cranial-vertebral joints are doing and its impact on these muscles to get the entire clear picture. So if I find a restriction here at C1 on C2, a little bit of hypertonicity in these muscles, I may try and clear that C1, C2 restriction first and then reassess the muscle tone. Once I get a normal glide and normal proprioceptive input in the joint and in the system, my hypertonicity in my muscles may cool down. That's probably the perfect time for needling then, because if I needle the muscles to kind of hit the reset button on the firing pattern here and get that input, whether it be segmental inhibition or descending inhibitory control in this region, then it's just a very nice way to finish. Now, again, needling these first, you may get that inhibition of these muscles, but generally what you'll probably find is that this is the patient that rebounds where they feel good leaving the clinic, but later that night or the next day, their pain returns and the system kind of returns to normal because it was a restriction at occiput C1, C1, C2, or C2, C3 driving the pain pattern for this individual. So if I want to, again, feel these muscles and palpate them, I usually have the patient lie supine. I can palpate between the transverse process of C1 and the spinous process C2, and I can have them look left and look right, and I should be able to feel these ipsilateral muscles kind of toning up in my fingertips.